Good evening and welcome to the Past, Present, and Future of the Affordable Care Act, sponsored by the CPH Lecture Series. I'm Dr. Monica Panelists, Associate Professor of History and Director of the Center for Public History at the University of Houston. We're so glad that you've joined us for this important conversation and for our first event of the 2021-2022 academic year. At CPH, our vision is to ignite an understanding of our diverse pasts by collaborating with and training historically minded students, practitioners, and the public through community-driven programming and scholarship. One of the ways that we do that is through this lecture series, which provides a unique opportunity for scholars, professionals, community leaders, and others to consider humanities perspectives directly related to the decisions they make. Tonight's conversation about the history and impact of the Affordable Care Act is the first in our year-long examination of the history of health, medicine, and healing in its many forms. Today's event and all of our CPH Lecture Series events will be recorded and posted to our website. To learn more about CPH, please visit us at uh.edu/class/CPH. We encourage you to add your questions to the chat box in the live stream at any time. These will be shared with our panelists in the Q&A portion of the event. This box is located on the right side of the streaming frame. Be sure to let us know if your question is directed to a specific panelist or to the group as a whole, and we will pass them along to our speakers. Allow me now to introduce our moderator, Dr. James Schafer. Dr. Schafer is an associate professor in the Department of History. His research examines the social, political, and economic history of American medicine and healthcare. His first book, The Business of Private Medical Practice, explains the market forces that influence the office, locations, and career paths of doctors in early 20th century American cities. He's currently working on another book that examines the practice of medicine during World War I, both on the home front and overseas in American base hospitals. I turn the Zoom over to you now, Dr. Schafer.
Hello, everyone, and welcome to this event. Thank you very much, Professor Panelists. Let me share my slides real quick. Okay, I'll assume that these slides are showing at this point, unless I hear otherwise. It is my great pleasure to introduce tonight's panelists, all drawn from our faculty here at the University of Houston. In assembling tonight's panel on the Affordable Care Act, the Center for Public History endeavored to combine expertise in healthcare policy, healthcare law, and healthcare politics. Our first panelist tonight is Dr. LeChauncy D. Woodard. She is director of the Humana Integrated Health System Sciences Institute at the University of Houston College of Medicine. Dr. Woodard's research and practice focus on ethnically diverse patients and communities and socioeconomic factors that influence health outcomes. Our second panelist is Professor Seth J. Chandler. He is a Law Foundation professor at the University of Houston Law Center, who specializes in insurance law and the application of mathematics and computer science to law. Of particular importance to tonight's topic, he has testified before Congress on the Affordable Care Act. Our third panelist is Professor Jennifer H. Clark. She is the Pauline Yelderman Endowed Professor in the Department of Political Science. Her areas of specialization include American legislative institutions, state politics, and public policy. Welcome to tonight's panel. Before we begin, I want to provide some context for understanding the origins of the Affordable Care Act of 2010. As a historian of medicine, I frequently teach about the history of healthcare reform in the United States. As I tell my students, in order to understand the complexities and shortcomings of our healthcare system in the present day, it is necessary to understand how it formed. Let's begin with a characterization of the healthcare system as it stood in 2009, the year during which Barack Obama began his first term in office, and the year during which his congressional allies drafted the Affordable Care Act, which ultimately passed by the narrowest of margins through 2009 and into early 2010. Much of what I will say about the healthcare system then still applies to the present day. In 2009, the United States had the most expensive healthcare system in the world. And although many Americans may rejoice at being number one, this is not the sort of contest that you want to win. The primary way to measure cost is by calculating what is called the national health expenditure for a particular country for a particular year. As defined by the Center for Medicare and Medicaid Services, national health expenditure measures annual expenses, quote, for healthcare goods and services, public health activities, government administration, the net cost of health insurance, and investment related to healthcare. So in other words, national health expenditure tallies all of the spending on healthcare, public or private, whether by an institution or an individual in a given year. And in 2009, $2.49 trillion were spent on healthcare in the United States. And that equaled $8,135 spent per person living in the United States that year. And that is what you can see on this particular slide is a graph of national health expenditure per person in the United States since 1960, when it first began to be tracked. And as you can see, there's been a steady, inexorable increase in NHE per capita in the United States. When you compare the United States to other wealthy industrial nations, such as Canada, France, Great Britain, and Germany, you can see here that national health expenditure per capita has not only been increasing in the United States, it's been increasing at a faster rate than in other comparable nations to the United States. It's not that other countries aren't experiencing inflation in their health expenditure, it's just that the United States is outpacing other countries in its inflation of health expenditure. Another way to look at national health expenditure and to assess the cost of healthcare in a particular nation is also to compare national health expenditure to the size of an economy or gross domestic product. And basically what this is an expression of the amount spent on healthcare, NHE, in a given year, and compared to the total size of the economy as measured by gross domestic product. And in the United States, over the same period of time, and when compared to the same peers, the United States spends a greater fraction of its gross domestic product or a greater proportion of the value of its gross domestic product on healthcare than comparable nations, and the rate of increase has also been faster in terms of the size of the economy that national health expenditure represents. So the US is the most expensive healthcare system in the world, and it's been getting more so as time goes on. But despite paying the most in 2009, the United States did not get the most. And if we take a look at a number of different ways of assessing healthcare system performance, such as life expectancy at birth and infant mortality, the ranking of the United States makes that clear. Here you can see a ranking of a bunch of nations that share data in what's known as the OECD, the Organization for Economic Cooperation and Development. And the United States in 2009 ranked 27th in life expectancy. The average among these nations was 79.5, and the highest achieving nation was Japan at 83 years of life expected at birth, almost 5 years more. However, in Japan, in that country, they spent 36 cents on the dollar to what Americans spent on healthcare in 2009. Similarly, if we take a look at infant mortality rates through the OECD, we see that the United States also fared poorly by comparison to other countries, ranking 31st in 2009 with an infant mortality of 6.5 infant deaths per 1,000 children born in that year. The highest achieving country in terms of the lowest infant mortality rate was Iceland at 1.8, and they spent less than half of the United States on healthcare. Not only did the United States pay more for healthcare, they also left more people out in the cold than any other wealthy industrial nation. On this bar chart, you can see a measure of the different types of health insurance. And you can see that in 2009, a little bit more than 16% of the US population was uninsured. That was 46.3 million people. And although 83% had insurance, the vast majority of those had private employment-based insurance, which means that their health insurance came as a benefit of employment. Now, the United States is practically the only wealthy industrial nation with a healthcare system that's dominated by private employment-based health insurance, and we pay the price in terms of our health and our pocketbooks. If we take a look at, in particular, the uninsured, not only does the United States have a greater percentage of its population uninsured then and still now than most other wealthy industrial nations, the burden of being uninsured falls heaviest on the most marginalized groups in the United States. The young, as well as African Americans, Hispanic Americans, and poor Americans have higher rates of uninsurance in 2009 and still to this day, although that gap has closed somewhat thanks to the Affordable Care Act. But another problem of having a healthcare system that's based on private employment-based health insurance is that when people fall on hard times, when people get laid off from their jobs, they lose their health insurance along with their paycheck. And few can afford to buy private health insurance without a job, without the employer contribution. At least that was the case before the Affordable Care Act. And in 2009, you can see that the United States, if you look at the bottom, experienced massive job loss. This began all the way back in December of 2007. The economy started to shed jobs, and in less than a 2-year period, more than 10 million jobs were shed from seasonally adjusted non-farm payroll jobs in the United States. This was known as the Great Recession, and at its peak, more than 10.5% of Americans were unemployed. The number of people who were uninsured in 2009, 2010 soared to 50 million people in the United States. So this was the context of the incoming administration of President Barack Obama in January of 2009. The economy was losing jobs at a faster rate than at any time since the Great Depression of the 1930s, and many Americans were uninsured, underinsured, or otherwise unable to pay their medical bills. Healthcare had long been a priority of the Democratic Party, at least in the United States. And I put up here just a very quick summary of the different attempts to pass greater public financing of health insurance in the United States. I won't go through all of them, but if there's time and interest in the Q&A at the end of tonight's session, I'd be happy to talk about more of them. If you take a look at this list, you'll note that generally speaking, most plans that offered comprehensive reform failed to win passage, notably in the 1930s when health insurance, publicly funded, did not make its way into the Social Security Act, which did pass. There were several other attempts, especially in the 1940s, to pass national health insurance, something like single-payer universal healthcare coverage, that never made their way to the floor of the House or Senate for a vote. The handful of laws that have passed expanding coverage have tended to be incremental in their scope, such as Medicare for the elderly and Medicaid for the poor, passed in the middle of the 1960s as amendments to Social Security, as well as an expansion of Medicaid to include a greater fraction of children living below the poverty line in the United States with the passage of S-CHIP and its renewal in 1997 and 2009. So this was the context for the Affordable Care Act coming into 2009 with the new administration. Taking a very quick moment to talk, I'll just go for about another minute before I turn it over to our first panelist. There were a couple of key innovations in the Affordable Care Act that helped it to succeed where other efforts had failed. First and foremost was this combination of what was called guarantee issue and the individual mandate. Basically, guarantee issue meant that no insurer could deny someone coverage for a pre-existing medical condition, which was a major problem leading up to 2009, and also one of the reasons why people were locked in their jobs, because if they switched jobs and lost coverage for a period of time, they might be uninsurable due to a pre-existing condition. But in order for insurers to be willing to be required under law to insure anyone who came to them asking for health insurance, there was also the individual mandate. The federal government required under ACA for every individual to be insured or pay a tax penalty. Now, as one of our panelists will talk about later, eventually that tax penalty was reduced to zero under budget reconciliation back in December of 2017. There were various mechanisms for paying for this law, but essentially people who lived below the federal poverty line, actually who lived below about 133% of federal poverty level, were supposed to receive Medicaid, and the federal government was going to help states expand their coverage up to 133% of FPL. However, the Supreme Court overruled that as unduly coercive, and states were left to choose whether to expand Medicaid, and many chose not to, leaving a coverage gap where some people were not poor enough to get Medicaid in their state, but not rich enough to start to qualify for federal subsidies to purchase health insurance if their employer didn't, which was the final kind of component of the Affordable Care Act that we'll focus mostly on tonight. That is to say, federal subsidy for people who didn't get insurance through their employer to buy it with federal subsidy depending on income qualifications. So with that, we can basically see the context in which the Affordable Care Act began to be drafted and ultimately passed in 2009 to 2010. What I want to do next is stop sharing my screen and turn things over to our first panelist tonight, Dr. LeChauncy Woodard. Take it away, Dr. Woodard. You're still muted, Dr. Woodard.
All right. Can you all see my screen and hear me?
We can see you and hear you. Thanks.
All right, perfect. So I'm really excited to be here this evening and really to follow up on Dr. Schafer's excellent history of what led to the Affordable Care Act and some of the provisions that were included in the Affordable Care Act. And tonight, in addition to hearing about the history that led to the Affordable Care Act and the provisions of the Affordable Care Act, we will also hear about some of the political challenges that have faced the Affordable Care Act and that have perhaps diminished some of the potential that the Affordable Care Act had to improve health and health outcomes. While I'm spending some time with you this evening, I'm going to share some information about how the Affordable Care Act has impacted insurance coverage, access to care, and health outcomes. And you will see that while there have been many positive effects of the Affordable Care Act, we've also seen some mixed effects when it comes to health outcomes. So we know at 10 years that the Affordable Care Act has undoubtedly transformed the American healthcare system by expanding access to coverage for approximately 20 million Americans. The Affordable Care Act, as you've already heard, has also codified protections for people with pre-existing conditions, eliminated patient cost sharing, specifically for high-cost preventive services, and helped to make healthcare more accessible for varied populations across the United States, especially, as we've heard, young adults, minority populations, and another population not focused on as much, women. While we know the Affordable Care Act has had a tremendous impact on our healthcare system, we also know that implementation has been complicated, that partisan conflict has prevented the typical improvements that we see with major legislation. So oftentimes when we see major legislation that's passed, we see incremental improvements to that legislation. But unfortunately, our partisan divide has prevented some of those incremental improvements that we typically see when we see major policy legislation that's passed. And we also know that broad discretion has been afforded to states, and that's resulted in variable impacts on the respective populations of those states. Despite some of those challenges, we know confidently that the number of uninsured individuals in the United States is at historically low levels, and that there have been some positive effects on cost, quality, and health outcomes, although those results are more mixed. So let's start with discussing insurance coverage. So in 2010, 48.6 million Americans lacked health insurance. The Affordable Care Act was initially projected to reduce the number of uninsured to 23 million by 2019, so at almost 10 years after passage. However, as we've heard, there was a major Supreme Court case in 2012, which limited the Affordable Care Act mandate of expansion of state Medicaid programs. So because of that, the number of projected uninsured was revised upward to 29 million following that 2012 Supreme Court decision. Nonetheless, we know that about 20 million Americans gained insurance because of the Affordable Care Act. This graph shows the number of uninsured and the uninsured rate among the non-elderly population. And importantly, the Affordable Care Act really helped to improve access to care among individuals who were young adults, because elderly adults had access to healthcare through Medicare, but young adults were often the ones who fell into that gap of not having coverage. So under the Affordable Care Act, millions of people have gained health coverage, and the uninsured rate dropped to historically low levels in 2016. However, under the prior administration, we started to see some uptick in the number of individuals who were uninsured. And we saw that in 2017, which was the first time since implementation of the Affordable Care Act that we had seen a slight increase in the number of individuals who remained uninsured. And the groups that saw the most significant increases in uninsured were African Americans, older adults between the ages of 45 and 64, children, and some middle income families who were above the poverty level and therefore not eligible for Medicaid. In addition, we saw the most significant increases in individuals who didn't have insurance between 2016 and 2017 in states that failed to expand Medicaid. In states that had expanded Medicaid, that number stayed relatively flat. Importantly, we've seen that the Affordable Care Act has helped to mitigate some of the disparities that exist between Latinx communities, African American communities in particular, and white communities with regard to access to insurance. So while the Affordable Care Act led to decreases in almost all income groups and all races, we saw that the rates of uninsured fell most sharply for individuals who were poor or near poor, and for Hispanics, Blacks, and Asians compared to white Americans. In addition, and I think this is something that is less talked about when we talk about the Affordable Care Act, we saw significant decreases in uninsured rates across almost all groups of women. And this is important because prior to the Affordable Care Act, a third of women who tried to buy health insurance on their own, meaning not employer-sponsored or public-sponsored insurance, were either turned down or charged a higher premium because of their health or specific health problems were excluded from their plans. And when we say specific health problems, we're talking about regular things like contraception or pregnancy. And so women had to pay gender-based premiums in order to get insurance, and that made insurance less accessible for women. However, beginning in 2010, the Affordable Care Act protections, particularly the coverage for preventive care screenings with no cost sharing, a ban on plan benefit limits, and provisions that allowed workers to enroll their dependents up to age 26 led to significant increases in coverage for women. And as a result, we saw that the percentage of women who reported delaying care or skipping needed care because of costs fell to an all-time low. So we saw that insured women were more likely than uninsured women to receive their preventive screenings, including things like pap smears and mammograms. This slide shows you the hypothetical application of individual health insurance benefits before and after the Affordable Care Act. And this goes back to the discussion that we've had about the Affordable Care Act limiting restrictions on providing insurance for individuals who had pre-existing conditions. And this is important because 27% of non-elderly adults have a declinable pre-existing health condition. And that accounts for about 54 million Americans. In addition, if you look at a family, almost half of families that have non-elderly members have at least one adult member that has a declinable health condition. So this provides an example to you of different aged individuals with different potential pre-existing conditions and what would have happened pre-affordable, what would have or could have happened pre-Affordable Care Act with regard to availability of insurance. So they could have either been rejected or had a substandard offer, meaning they had higher premium costs or other exclusions that limited ability to receive care. And that would have happened to a majority of individuals, including someone who was 24 with seasonal allergies. But with the passage of the Affordable Care Act, individuals who had pre-existing conditions could no longer be denied coverage based on that pre-existing conditions or charged higher premiums. So we saw that post the Affordable Care Act, individuals with pre-existing conditions were able to receive better coverage that allowed them to receive the health care that they needed. And one final thing about insurance coverage, importantly, as I've mentioned, states that expanded Medicaid had lower rates of uninsured than those that didn't. And Texas is one of those states that chose not to expand Medicaid. And as you can see, actually, it's really southern states that most often have chosen not to expand Medicaid and where the majority of uninsured individuals who would benefit from that expansion live. So if just 4 states expanded Medicaid, Texas, Florida, Georgia, and North Carolina, you would cover an additional 4.4 million Americans. And importantly, for context, approximately 5.2 million Texans were uninsured last year, and that's about 18.4% of our state's population, making us the state with the highest number of uninsured individuals and double the national average of about 9.2%. So now we'll talk a little bit about the effect of the Affordable Care Act on access to care. And as you can see, I won't read this, we've talked about this. There are certain things that insurers can no longer do, including denying coverage for pre-existing conditions. And insurers must also now cover preventive services. And you can see that that affects a significant number of Americans.
1 minute, Dr. Woodard.
Because of this increased access to care, we've seen that individuals are not skipping necessary services, and that we've seen improvements in financial security, meaning we've seen fewer people having bankruptcy due to catastrophic medical expenses. We've seen decreased out-of-pocket expenses for individuals who are receiving medical care. And as a result, we've seen fewer people who are reporting problems with paying their medical bills. And as I mentioned, problems with having to skip necessary services, fill their prescriptions, or not get care when they need it. This all, in some ways, can contribute to better health outcomes. Nonetheless, we see that while we've seen significant improvements across a large number of metrics used to assess the success of the Affordable Care Act, the area where we've seen the most mixed results is in actual quality of care, self-reported health outcomes, and health outcomes in general. We have seen some positive effects, especially for chronic conditions like diabetes and heart failure, but there is much more work to do and much more to be studied with regard to the impact of the Affordable Care Act on health outcomes. And we can certainly discuss these more as we move into our question and answer period. So with that, to summarize, we know that the Affordable Care Act has led to fewer uninsured, greater access to care, but we also know that the impact on cost and quality has been mixed, and there's still a lot for us to learn with regard to the impact of the Affordable Care Act on these particular outcomes. And with that, I will turn it over to our next speaker.
Thank you, Dr. Woodard. I just want to mention before we go to our next panelist for tonight that if you have a question you'd like to ask of one of our panelists, to please type it in the chat in the lower right corner of your Zoom window. We will be happy to answer your questions later on. With that, I turn to our next panelist, Professor Seth Chandler. Take it away, Professor Chandler.
Well, thank you. 1 second. So I'm going to talk about the legal history of the Affordable Care Act, and really it emerges mostly out of the central challenge it created for itself, which is the key, as Dr. Woodard described, was to remove a crucial stabilizing feature of an insurance market, which are premiums that are linked to expected costs, and still to somehow get that market to function. And there was good reason to fear that it might not. States that had previously attempted this, and I've got a list in the slides, had really had very poor results. They'd fallen into something very close to an adverse selection death spiral. And so the Affordable Care Act contained a number of mechanisms, some of which challenged constitutional boundaries, to try and prevent a similar result when that crucial stabilizing feature was removed. And it fell into the carrots and the sticks. The carrots were the large premium subsidies and cost sharing reductions so that even people who were low risk had an incentive to buy insurance. It has risk adjustment, the little dark secret of the Affordable Care Act, that decouples the amount that the insured pays from the amount that the insurer receives, and instead creates a shadow system of classification. Transitional free reinsurance to insurers that would quietly subsidize them for taking on high risk insureds. The stick was starting in 2014, there would be a requirement to maintain minimum essential coverage and a penalty that would grow to $750 for each uninsured person for whom you had responsibility, or 2.5% of your income, whichever was bigger, all capped by the price of a bronze policy. This is called the individual mandate. There was also an employer mandate, which has been somewhat less controversial from a legal perspective, but is still a very important feature of the ACA. So we have two cases that really address the individual mandate that are sort of the bookends, I would say, to the discussion. One is NFIB versus Sebelius in 2012, which challenged the mandate, and then California versus Texas in 2021, which challenged the repeal of the mandate. So the issue that we started with was, where does Congress actually get the power to regulate insurance? Because Congress cannot just regulate whatever it pleases. The federal government is one of enumerated powers only, not plenary police powers. At least that's the traditional idea. There were at least three powers that were offered up to justify forcing people to buy insurance. One was that it constituted the regulation of interstate commerce, which had been held constitutional since 1944. Second was a power to tax, because since 1936, at least, it's been held that Congress can tax things that it cannot regulate directly. And third was to say that it was necessary and proper to the execution of other powers. That is, the Constitution doesn't actually say that Congress can make it a crime to assault a postman. But that's an implied power, because otherwise Congress wouldn't have a very easy time creating post offices and post roads, which it does have the power to do, if people could just assault policemen or postmen. And a necessary had actually been interpreted by the Supreme Court and Chief Justice Marshall to not mean strictly necessary, but to mean convenient. And so you might have thought this was an easy case. Most of what's in the ACA, such as abolition of most classification, expansion of Medicaid, was within Congress's power under the Commerce Clause. So that was easy. But to make it actually work, it was thought that it needed an individual mandate, that stick to get people to buy insurance to prevent the creation of an adverse selection death spiral. And ACA advocates argued forcefully at that time that it was absolutely essential to ACA stability, so that even if a naked mandate to purchase something like sticking that broccoli in front of Kevin from the office might be unconstitutional, a mandate integrated with an otherwise legitimate statute would be okay. And people threw in the argument that, well, if that doesn't work, maybe it's a permissible tax. So the Supreme Court in 2012 in NFIB versus Sebelius says that a naked mandate is not okay under the Constitution, that Congress you can't create the commerce. The commerce has to exist in order for it to be regulated, and to force people to buy something was not regulation of commerce. And so the broccoli hypothetical basically wins. With that left, well, what about the integrated mandate? Isn't that necessary and proper to buttress the remainder of the ACA? And the Supreme Court says, well, maybe it's necessary, but it's not proper. And propriety, which is now a tool that can be used by activist judges, would be determined partly by tradition, and we'd never seen this before, and partly by thinking through implications which the court didn't like. And so the Supreme Court rules that it is not within Congress's commerce power, which led CNN and Fox to go rush out and tell people that they'd struck down the ACA. But that's because they didn't read the rest of the opinion. The court then says, well, maybe it's a tax. But it then has to deal with this issue that under federal law, in order to challenge a tax, you have to pay the tax first. But no one would owe the tax until 2014. And that created a problem, like you have this major statute. And are you really going to say that we can't decide on it until 2015 or so, until people have paid the tax? So the Supreme Court comes up with a magical and much criticized solution, which was to say that the mandate is not a tax for purposes of the Tax Anti-Injunction Act, but it is a tax for purposes of the Constitution. And so the Supreme Court upholds the individual mandate as a tax. Fast forward, the Supreme Court in that Sebelius case basically says, Whether you want to tax people for not buying health insurance is up to the political system. And the political system in 2017, after the Republicans had failed on many occasions to repeal large parts of the ACA, it does manage in the Tax Cut and Jobs Act to zero out the tax. Technically, it doesn't repeal the mandate. Basically, the statute now reads, as it is today, you must purchase minimum essential coverage. And if you don't, well, actually nothing happens. So the ACA opponents seize on this and they say, oh, the only reason you said that the mandate was constitutional was because it was a tax, but now it's not a tax. And so the individual mandate is unconstitutional. And no one really cared because there wasn't an individual mandate. But they went on to say, and you told us back then that the individual mandate was essential to the ACA. And so under a legal doctrine called inseverability, since it's essential, maybe the Congress wouldn't have enacted the ACA if it had known it didn't have a mandate. And so now the entire ACA is unconstitutional, or if not, at least significant important chunks of it are unconstitutional. And so you have a lawsuit that's brought by various individuals and states, including the state of Texas under Ken Paxton and Governor Abbott. And they win. The United States District Court for the Northern District rules that the whole Affordable Care Act is now unconstitutional. And why did you miss that piece of news? You missed that piece of news because the judge said, well, I know that's controversial. Let me see what the Fifth Circuit has to say. The Fifth Circuit, which it's appealed to, says, yes, you're right, the mandate's unconstitutional. But as for the rest of the ACA, District Court, you did it all wrong in trying to figure out whether it was severable. Both courts, though, find that the individual plaintiffs and the states are harmed by the existence of an unconstitutional statute. So up we go to the Supreme Court, and the Supreme Court tells us, you know what? We're not going to tell you whether the ACA is now unconstitutional or whether any part of it is unconstitutional, because actually there is a much bigger problem with your lawsuit, which is Texas and person, you are not hurt. How are you hurt, asks the Supreme Court, by not being taxed? And the Constitution has never permitted federal courts to handle imaginary disputes where there's no concrete injury. There's a famous letter that the Supreme Court sends to George Washington, President George Washington, who'd asked the Supreme Court to help him out on some law issues. And the Supreme Court says, well, we're sorry, we just don't give advice on abstract issues. And if it was good enough for George Washington, it was good enough for President Biden and Trump and the rest. So we have that the mandate is held constitutional, and the repeal of the mandate doesn't kill the ACA because there's really nobody that's hurt. So we have this other part to go back to 2012 about the Medicaid expansion. And in many ways, I think that's probably the most important part of it as sort of a historical matter. It's the thing that's led to the greatest increase in coverage. And the way it worked was that the states were required to expand Medicaid to people with incomes below 133% of the federal poverty level. And the federal government would reimburse the states for the resulting expenses at a rate that's higher than they do for traditional Medicaid, but ultimately not for all of it. And so while the states might get a big benefit and their citizens might get a big benefit, the states were going to have to find a way to pay for those remaining costs. And, says the original ACA, if you don't expand Medicaid, you not only do you not get that money, you don't get any Medicaid money. And that was in many cases more than 10% of state budgets. So the states object. They see this as, some states object. They see this as commandeering. You're basically raiding our treasury. You're surprised. And the Supreme Court back in 2012 agreed. They said the Medicaid expansion was a gun to the head. It was coercive because no state could really afford to drop 10% of their budget. So instead of saying at that time, which they were urged to do, that the entire ACA is unconstitutional, or to say that the Medicaid expansion component is unconstitutional, instead the court used what's sometimes called a blue pencil and fixed the statute to make the Medicaid expansion optional. But of course, that's not really what Congress had contemplated. And as a result of the way the statute was drafted, that meant that people earning less than 100% of the federal poverty level in non-expansion states could not and still cannot get either ACA subsidies or Medicaid. There is, by the way, a proposal pending in Congress for non-expansion states. The way they're going to deal with non-expansion states is to let those people buy ACA policies at extremely low rates. Let me just say there are many other lawsuits about the ACA. I want to mention two of them here for the sake of completeness. One is King versus Burwell, which is about whether those states that declined to create their own exchanges, whether the federal government was obligated to provide premium subsidies in those states. Because if you look at the actual language of the statute, it only provides for subsidies for people who are enrolled in through an exchange established by the state under Section 1311. And so people who don't like the ACA seize on this and say, oh, but that means you can't do it for people who live in states that don't have their own exchanges. So the Supreme Court basically goes through what's the purpose of the statute. And ultimately, per Chief Justice Roberts, says, no, this language established by the state is broad enough to mean including the federal government too. We also have the collision, as everything seems to have, of the ACA with abortion issues and contraception issues. So we have an employer mandate that requires employers to provide coverage that meets certain standards. One of those standards is interpreted to be, you've got to provide contraceptive services to women. And some people consider that some methods of contraception that are authorized constitute abortions. So whether that's true or false, that's what they believe. So we've got Hobby Lobby, which I'm sure you know, which is a closely held corporation. It's owned by a few people. They're very religious. And they say that under a federal statute, the Religious Freedom Restoration Act, they can't be forced to basically sponsor contraception/abortion in this manner. And the Supreme Court basically agrees with them and says that closely held corporations can exercise religious freedom, and that the accommodation that the Obama administration had made to try and finesse this did not meet the strict scrutiny standard that RFRA requires. So actually, the ACA has generated all sorts of legal issues that go beyond the ACA. It's narrowed what interstate commerce means. It's permitted the courts to strike down federal laws as not proper. It's made a lot of law on severability and blue pencil, a lot of law on statutory interpretation, including for any lawyer friends out there, the Chevron doctrine, and it's interpreted what it means to burden religion under RFRA and much more. And with that, I will stop and leave it to the next speaker.
Thank you so much, Professor Chandler. And once again, I just want to ask the audience to please type in any questions you have for our panelists into the chat, and we will get to them in a short while. And if you'd like, you could indicate which panelists you'd like to answer your question. With that, I want to turn to our next panelist, Professor Jennifer Clark. Take it away.
Thank you. Let me share my screen. Right, so I'm going to talk about the politics of the Affordable Care Act. The debate over healthcare reform came during the 111th Congress, as Professor Schafer was talking about earlier. After President Obama was inaugurated in 2009, he had announced that comprehensive healthcare reform was at the top of his agenda. So with unified Democratic control of Congress, and actually a filibuster-proof supermajority in the Senate, as rare as that is, the conditions were quite conducive for the policy to pass. However, we can see from the figure over here on legislative productivity that even under situations of favorable political conditions, passing bills can be a challenge. So during most of these sessions, we see that upwards of 10,000, sometimes even more bills are proposed in Congress, but oftentimes only fewer than 500 are actually enacted. And so that's only around 5%. And many of those bills that are actually enacted concern reauthorizing existing programs, as well as ceremonial legislation. And so that's just to give you some context for just how monumental it would be to pass comprehensive healthcare reform. It's a major accomplishment, even when the conditions are conducive in terms of party control. So of course, the tendency for gridlock is in large part caused by the very design of our political system, separation of powers, bicameral legislative structure, as well as the legislative rules in place, such as the filibuster. However, as the second graph shows, if you can sort of see that, it breaks out party polarization by the House and Senate. And you can see they track fairly closely. And you can see that on roll call votes, that since the 1970s, there's been a steady rise in party polarization. And that's profoundly influenced what bills actually receive votes in Congress, as well as ultimately what gets passed. So partisanship has had a significant influence over policymaking, and certainly in the case of the Affordable Care Act. It passed without a single Republican vote, and that's not necessarily due to Democrats failing to try to involve the Republicans in the process of formulating the bill. It's just ideological differences sort of gotten in the way of compromise and bipartisanship. Additionally, it wasn't necessarily smooth sailing with the Democrats in Congress either. There are factions within the Democratic Party, such as the Blue Dog Democrats, who were concerned with costs of some of these programs, as well as progressive Democrats wanting a public option, and even pro-life conservatives who wanted some assurance that abortions would not be covered by government. And so they all had a seat at the table agitating to get their own perspectives heard. But ultimately, these divisions were overcome for the bill to pass, but not necessarily without casualties. So many vulnerable Democrats who supported the ACA, those in more conservative leaning districts, lost their reelection bids, and Republicans ended up gaining control of Congress. And so many of them had run on a platform of repeal and replacing the ACA. So since then, Republicans in Congress have voted more than 70 times to repeal and replace the Affordable Care Act. Healthcare reform and the ACA has also had a prominent role in presidential elections. We saw this front and center in the Democratic primary. We saw policy disagreements highlighted when progressives expressed their support for Medicare for all, while more moderate Democrats supported keeping the ACA and essentially modifying it to expand coverage. So how does the public feel about the Affordable Care Act? These data are from the Kaiser tracking poll and simply track whether individuals are favorable, that's the blue line, or unfavorable, the gray line, towards the ACA. We can see here that there's been a lot of fluctuation over time. We see favorability was sort of at a low in 2013 and 2014 as Medicaid expansion was coming into play. However, for the first time in 2017, favorability of the ACA actually crossed the 50% threshold, and its favorability since then has steadily risen, although we do see some dips as well. Now, this chart shows how partisans and independents rate their favorability towards the ACA. So during this entire time frame, there's been no overlap. That's the first notable point of this figure between the favorability of Democrats, independents, and Republicans. Democrats are consistently more favorable towards the ACA compared to independents and Republicans. We also see, though, that favorability has increased among Democrats and independents, especially since 2018. Republicans' favorability has been consistently below 20%, though. So what explains the fluctuations in public opinion on the ACA? Why do we see some increases in favorability overall since 2017? One major theory proposed by political scientists that explains the variation is something known as policy feedback theory. And this is based on the notion that public policies cultivate and create their own politics. There are several ways that this can actually occur. One is simply through gaining insurance through the ACA might increase recipients' sense of stake in public affairs or make recipients feel more incorporated into the political system as deserving citizens. Another is policy threat that can boost participation among the social program recipients. And finally, we can also see backlash, especially amongst Republicans who never seem to support the policy. And since the states were given considerable discretion in implementing many of these provisions of the ACA, political scientists have used that variation across the states to better understand how implementation of the ACA has shaped citizens' attitudes about the policy, as well as their political participation. So there's been a lot of research examining Medicaid expansion. We heard about the NFIB ruling and that participation and expansion became voluntary after 2012. So currently 12 states have opted not to expand their Medicaid programs. And one of those, of course, is Texas. So there's been some research finding support for policy feedback effects with respect to Medicaid expansion. A couple scholars, Michael Sonses and Joshua Clinton, found that expansion of Medicaid made respondents about 1.5 percentage points more positive towards the ACA and over 2 points less likely to support repealing the law. They also found that it increased political mobilization among Medicaid eligible individuals. So they participated in politics and elections more frequently. My colleague Ling Zhu and I also find policy feedback effects. We found that beneficiaries of Medicaid expansion had significantly more positive views of the ACA post-expansion. There's also been research investigating the state exchange implementation that has shown some support as well for the policy feedback theory. So the gap between Republicans and Democrats in favorability towards the ACA was smaller among those who gained insurance through the marketplace compared to those who are on employer-based insurance or simply uninsured. Also, those with personal or family experience in gaining insurance using the subsidies. There was a positive, favorable impact in terms of health access, they reported in a survey. And finally, scholars have looked at the dependent care provision that essentially allowed those age 26 and younger to remain on their parents' health insurance. This line of research, however, didn't find any support for the policy feedback theory. So there was a study that compared political participation among those right above that 26 threshold and those right below it. And there didn't seem to be any significant difference in voter participation or support for the ACA among those two groups. And so the limited effects could be attributable to the fragmented nature of the ACA, or often we talk about the hidden sorts of policy design elements. So many citizens don't necessarily even link their health coverage to provisions from the ACA oftentimes. And so those are some ways that it's had limited effects. We've also seen backlash and negative feedback effects. For instance, in some Republican states that opted into Medicaid expansion, Ohio, Missouri, actually through ballot initiatives, we've seen governors subsequently apply for waivers from the federal government to implement work requirements for those recipients. And we've actually seen policy diffusion where those ideas have spread to other states, other neighboring states. with Republican governors as well. So just thinking about the ACA in 2021 and beyond, the coronavirus pandemic has led to renewed attention to this issue of the lack of insurance, the high number of uninsured, especially in states like ours, Texas. As Dr. Schafer was saying, you don't necessarily always want to be number one, right? And so Texas has the highest uninsured rate at an estimated 4.9 million. So that's about 20% of the population here. We've seen with the pandemic response legislation, we've seen financial incentives included in that legislation for those states who haven't already expanded. If they do expand, they're going to receive an additional 5% federal matching funds. And so that's sort of seen as a carrot to entice some of these holdout states to expand their programs. However, thus far, it hasn't really appealed to any of the Republican governors, though. And then congressional Democrats have actually proposed another approach to try to expand health insurance coverage. It's called the Cover Now Act, and it would allow local government to implement their own Medicaid expansion. So that would allow the federal government to contract directly with local governments to expand Medicaid. Essentially a way to sort of circumvent Republican state officials who have opposed Medicaid expansion. So it's very likely we'll see less turbulence and more efforts to expand coverage, contain prescription drug costs, and address racial health disparities in the future. Thank you.
Thank you, Professor Clark, very much for that. And thank you to all our panelists for your presentations. So we are starting to get some questions coming in from the audience at this point, which is great. Keep the questions coming in. I did want to start off with a couple of questions, kind of get discussion going amongst our panelists and to have some intellectual cross-pollination among the different disciplines represented here. So one question I wanted to ask you all is, in the run-up to the passage of the Affordable Care Act, and certainly in its wake, there have been a variety of criticisms of the Affordable Care Act, and I think we can kind of put them into two buckets, right? We can have the sort of bucket for disingenuous and absurd critiques, death panels, socialism, all the rest of it. But then I think there's another bucket that we could maybe put more genuine and critiques, ones that maybe have proven to be a little bit more pithy than originally anticipated. So I wonder if you could each speak in your relevant disciplines to critiques in the early days of the Affordable Care Act that have actually proven to be, to have some staying power as time has gone on. So why don't we start with Dr. Woodard?
Yeah, thanks so much for that question. That's actually a really great question. I think, one of the criticisms of the Affordable Care Act is that, we talked about it providing universal coverage, meaning that everyone would have access to health care and health insurance. And we've certainly seen that that's not the case, even though a large number of people gained access to insurance and therefore access to health care. Many people still have not. And again, I think Texas provides one of the starkest examples of that. And so I think that that is a criticism of the Affordable Care Act that has certainly had staying power, and that, there is some truth to. I think one of the other criticisms was that there would be sort of this influx of individuals who had now insurance coverage and not enough healthcare providers, right, to take care of those patients. And initially we did see in some states that there were kind of waiting lists for people to be seen. But in general, I think a lot of the provisions of the Affordable Care Act offered support to increase the number of providers who could care for patients. There was $11 billion included to expand the capacity of community health centers. There was more funding given to train individuals who would go into primary care and work in underserved areas. I think some of that was effective. But what we have continued to see is that areas that had lack of access to these primary care providers, even with some of those provisions, that lack of access has continued, right? So where we had shortages in primary care providers and we had areas with unmet demand, whether it's inner city areas or rural areas, we've continued to see some of that lack of availability of healthcare providers. So those are two things that I would say, criticisms of the Affordable Care Act that proved to have some staying power.
Yeah, and I think we maybe characterize those as perhaps criticisms from the political left that the Affordable Care Act didn't go quite far enough in getting us towards universal health care. Would you agree with that, Professor Clark? From the political left, if we'll use this kind of clumsy characterization, have had some staying power.
I agree with that, and I agree with what Dr. Woodard was saying. Also, a few other things I think in terms of containing costs, that's still a problem, but much of that is just by the design with federalism. And so in Texas, we still see spiraling healthcare costs, but it hasn't sort of been implemented to the fullest extent. We don't have Medicaid expansion and so forth. And so containing costs would be another area, as well as addressing health disparities amongst racial and ethnic minorities, as well as women. I think that's one area where we could see more. And I think that also is likely more of a criticism from the political left as well.
Thank you. Professor Chandler, what do you think? Are there some criticisms that have gone the distance and proven to be quite valid and useful in thinking about the Affordable Care Act? Could you unmute?
One criticism that is certainly factually valid is that the financial estimates of its costs were way off. It has been much more expensive on a sort of per newly insured person than was anticipated, although it seems to me, at least, as if Congress has basically decided we don't care, and you're seeing yet further expansions of the Affordable Care Act, and no one quite knows where the money for any of this is coming from. So that's one issue, which I think the criticisms were that these initial CBO estimates were really pretty trashy, has shown some sticking power. The other issue is fears that it would lead to concentration of the health insurance market. That is, there were these hopes that there would be these co-ops and these innovative things, and it would lead to greater competition in the health insurance market. And in fact, in my opinion, significantly because of the clumsy way that the risk adjustment program was implemented, the health insurance markets have become more concentrated since the Affordable Care Act was passed, and that can lead to certain problems for the provision of medical services. On the legal side, I would say there are two things that people were dubious about at the time of the original NFIB versus Sebelius decision, which I think on rereading the decision, gosh, it does look a little shaky. One was Chief Justice Roberts' decision that this wasn't a tax for purposes of the Tax Anti-Injunction Act, but it was a tax for purposes of the Constitution. That's a pretty bold piece of statutory interpretation legerdemain. And the other is the blue pencil doctrine, because what they ended up with was a statute that Congress did not contemplate. That is, they ended up with a statute in which people earning less than 100% of federal poverty level were basically getting nothing in non-expansion states. And I have serious doubts that Congress would ever have written such a statute. On the other hand, the alternative facing Chief Justice Roberts, which was endorsed by many of his more conservative colleagues, was, well, we'll just ditch the whole Medicaid expansion. And I suspect that would not have played particularly well. So a number of features of the ACA that I don't think have worked out as well as proponents have hoped, and some actually have worked better than some people, including me, had anticipated, such as the stability, the ability of the markets to be at least somewhat stable.
Thank you for that. I want to kind of weave in some questions from the audience as they come in, make sure that we have plenty of time to get to all questions from the audience. One question comes in that I think pertains to what we were just talking about. What do you think it would take for Texas to expand Medicaid? And I think this is probably a question that could be answered from all three of the disciplines represented tonight, certainly legal, certainly political, and I think probably Dr. Woodard, if not from the medical side of things, at least could talk a little bit about what Medicaid expansion might mean for Texas if it were eventually to pass. So why don't we talk about the politics of it first, if we could, Professor Clark.
Sure. Yeah, I think in terms of Medicaid expansion, I mean, they're going into the legislative session earlier this year. There was a great deal of hope that, there could be some bipartisan solution and the state legislators could work together and they could eventually expand Medicaid. However, it seems that it simply fell apart. And so I don't have high hopes that we could sort of go the traditional route of the legislative process and that Governor Abbott would suddenly be on board with expanding Medicaid. And that's why I do believe the congressional Democrats have come up with this way to sort of circumvent the process and go directly to local governments who could then contract with CMS and they could expand the coverage that way. And so politically, I'm a little hesitant to say that I feel like they could get it done in the next couple years. It's probably best through contracting with local governments and working it that way to expand the coverage.
Yeah, and certainly if we look back and compare 2018 to 2020 in Texas, the hope of 2018 with Beto O'Rourke coming so close, and then 2020 with very little achieved in terms of change in party control or even moving the needle at all, suggests that at least for the time being, Texas remains in the gridlock with regard to party divisions along the lines of Medicaid expansion. All right, from a legal perspective, what would it take, Professor Chandler, or what do you think, getting to the question from the audience, what do you think it would take for Texas to expand Medicaid? Are there any legal impediments?
Legally, it can do it. It requires passage of a statute by the Texas legislature. The implications, though, are quite significant, which is that this would be an expensive proposition for Texas that would require some revamping of its tax structure to pay for it, because although the federal government is going to subsidize much of the expense involved in expanding Medicaid to 4 million, 5 million people, it's not going to pick up the full bill. And so Texas is going to have to figure out how to finance that. Now, yes, there would be savings from not having to provide coverage to various state hospitals and other state programs, but I think on net, it's going to require some additional payment of money. Let me also just address this Cover Act, which I think is a really interesting idea of asking bypassing the states in effect and working with perhaps more liberal cities to expand Medicaid. And I just wonder whether that's not going to run into some constitutional challenges, because I suspect the state of Texas and other states that are conservative are not going to be excited about Houston or Dallas, in some sense, Medicaid seceding from the great state and cutting deals on their own with the federal government. And so we're going to have issues about whether this constitutes effectively commandeering of the state sovereignty, and we're going to see the 10th Amendment prominent. The other thing I would say, though, is there is an interesting idea pending in Congress, which is to bypass the failure of states to expand Medicaid and to extend ACA coverage to those people. That coverage might not be quite as generous as Medicaid provides. On the other hand, it avoids the stigma and issues sometimes associated with Medicaid. And a lot of those policies are going to be free to individuals given the current rate of subsidies and will provide 94% actuarial value. So I'm not saying it's a panacea, but I am thinking that it might be a quicker path to actually deliver viable health insurance coverage than trying to cut deals with cities against the wishes of the parent state.
Thank you. I guess a question to follow up on just that before getting to Dr. Woodard, is there a mechanism for a statewide referendum to go the route of, I guess, was it Missouri, to expand Medicaid in the state of Texas? I mean, we do have statewide referendums, or is there any mechanism for something like this to take place through statewide referendum?
Yeah, I'm going to confess I am not an expert on state referendums.
There actually isn't in Texas. And so it varies according to the states in terms of their constitutions. And so we don't actually have that provision where by petition we could get a policy such as that directly on the ballot. And so that's also a challenge within the state of Texas. The other states, they can sort of, take it to the citizens. Of course, in Missouri, the legislature pushed back and they tried to undo that ballot initiative, but ultimately it stands.
And we've seen that same kind of pushback for other sort of medical related statewide referendums, such as medical marijuana, was it in Montana, where there was a statewide referendum and there was pushback from the government, and then ultimately the government was compelled to permit that. Getting to Medicaid policy a little bit, and Dr. Woodard, I mean, looking at kind of Medicaid coverage state by state, one of the things under the 1960 law that was entitled was for states to come up with a plan to define eligibility and coverage. And obviously it had to go through the federal government, and then there was dollar matching by the federal government according to some formula. But if you look in the present day, Texas has one of the stingiest Medicaid eligibility programs. And there's plenty of individuals, if they don't meet the right marital status or household structure status, doesn't matter if they earn $0, they don't get any Medicaid. It really, really depends. So maybe you could talk for a little bit, getting back to this question from the audience about Medicaid in Texas, about some of the consequences for Texans in terms of health, especially for the poorest Texans who don't qualify under Texas's very stingy Medicaid eligibility standards.
I think that's such a great question. And to your point, not only did we not expand Medicaid, but we have terribly stingy requirements with regard to who is eligible for Medicaid. So, we have huge numbers of individuals in our state who go uninsured and who can't get access to the care that they need. And importantly, I think if we expanded Medicaid in Texas, I wouldn't expect really to see anything different than what we saw in other states that expanded Medicaid. Now, as I mentioned, the impact on health outcomes has been mixed, but we know that individuals who got access to health insurance through Medicaid expansion were more likely to utilize healthcare. So they were more likely to engage in primary care visits, right? Which will allow you to address health concerns earlier and avoid using mechanisms like the emergency room or those sort of last resort places of care. We also know that individuals who had access to insurance were more able to access the medications that they needed to manage their chronic medical conditions. Again, they were more likely to get checkups. They were able to get preventive care, including cancer screenings, which allowed for certain conditions to be diagnosed at earlier stages, which then leads to the likelihood of a better outcome for those particular conditions. So again, we also know that individuals who were able to access care and who had insurance had less financial strain associated with that. And that too has a health impact, right? Because there are lots of mental health consequences of the financial strain that comes along with not being able to access needed care and not being able to pay for the care when you do have to access it. So I think when we think about it in its totality, expanding access to care through Medicaid expansion in the state of Texas would lead to similar positive health outcomes for our citizens. It's just a matter of finding that political will to get it done. And I'm not convinced that in the state of Texas that actually exists. And as a result, we see, the highest rate of individuals who are uninsured here in our state.
Thank you very much. Another question from the audience. To what extent has the current pandemic, changed people's perceptions of ACA? And I think the kind of a way to make this applicable to all three disciplines represented is maybe from the legal perspective to think about what has the legal status of the pandemic or the legal issues raised by the pandemic meant for the prospects of the Affordable Care Act going forward. And I guess on the health policy side, what has the pandemic told us about the problems of people being uninsured, and maybe in terms of changing people's perceptions of ACA? And then I think, of course, on the political side of things, Professor Clark, what has the politics of the pandemic meant for the way people think about ACA? And perhaps this is more speculative because we're still in this, and I don't know if there's enough academic research yet. So maybe I'm asking you to speculate or get out your crystal ball a little bit to think about how the pandemic may change public perception and the meanings of ACA in public discourse. So why don't we start maybe with politics, Professor Clark?
Sure, and I don't have any sort of hard and fast data on this. Although there have been some polls kind of looking at the most important problem question, and we actually have seen that healthcare has consistently been on the rise in terms of one of the greatest problems facing the United States. And also there's some polling in Texas that suggests that it's on the public's mind here. And so, if that's suggestive of anything, to me, it would suggest that elected officials are also sort of thinking about how to address some of the challenges, including, of course, the high rate of uninsured, the costs of these programs, as well as simply looking at, with respect to employer-based insurance and many people losing their jobs, how to sort of address that and stabilize those conditions in the future.
Thank you. Thank you. Dr. Woodard, how does the Affordable Care Act look relative to the current pandemic?
Yeah, so I would say that the pandemic and the sheer numbers of individuals who lost employer-sponsored insurance because of layoffs, I think makes the Affordable Care Act, at least for me, much more attractive, because you have individuals who not only lost their employer-sponsored insurance, but are living in the context of a pandemic where there's an increased risk of serious illness and death, having access to medical care through insurance and subsidies provided by the Affordable Care Act. So I think that's the first thing, as Professor Clark stated, right? That loss of work and then loss of employer-sponsored insurance. So it offers some protections, although not fully against that. I think the other thing that we've seen with the pandemic is that individuals who have chronic medical conditions have had poorer outcomes, have had more severe COVID-19 related illnesses, have been more likely to be hospitalized, to require care in the intensive care unit, and to die because of COVID-19. So having insurance and the ability to have those medical conditions treated and hopefully be controlled has certainly provided some comfort to individuals, right, who have those conditions, and hopefully made them more able to navigate COVID-19 and if they became ill with COVID-19. The other thing that we see is that coverage allows for other preventive services. So as we think about the approaching flu season, right, we know that the likelihood of this sort of collision of influenza and COVID-19 could lead to poor outcomes, especially among communities that are increased risk. And there are a lot of communities that fall into that realm, including those with pre-existing conditions, older adults. And so it's important to recognize that this also allows for access to preventive services. And then one thing that we don't quite know yet is whether or not COVID-19 becomes a pre-existing condition for the numbers of individuals who've had COVID-19 or and many of whom are at risk for, long COVID or other potential health consequences related to COVID-19. So if we go back to that provision that prevents people from being denied healthcare coverage because of pre-existing conditions, we have to wonder what the impact will be on the large numbers of individuals who've had COVID-19 and if that is classified as a pre-existing condition. So I think many of those things, when you take it in its totality, make the Affordable Care Act look even more promising and important in helping to manage the health conditions that we see among Americans.
Yes, and the memory of what it was like to live in a health insurance world where pre-existing conditions were a constant menace, a constant risk that someone faced is fading, I think, from public memory, especially for young adults who are too young to remember what the world looked like in the United States before that. Professor Chandler, what do you think? What kinds of constitutional issues have been raised in the pandemic that have maybe caused legal scholars to look at the Affordable Care Act in a different way, or perhaps imperil it in new ways?
Yeah, I don't have a great answer for that question, but I do have a good answer for some of the other legal changes, which is the pandemic actually catalyzed the biggest changes in the Affordable Care Act since it was enacted, which is the expansion of subsidies to people earning more than 400% of the federal poverty level. And I think from a political and economic perspective, that's a huge deal. That brings the middle class into the list of people who are directly benefited by the Affordable Care Act and who now don't have to resort to sort of band-aids like short-term health plans and other band-aids that had been developed, but can now actually afford healthcare coverage through one of the ACA exchange insurers. That's a big deal. Also, with one of the things the rescue plan did was to provide very high levels of subsidies to people who had been laid off at any point during the pandemic. That again, if we think about Professor Clark, and I'm trying to remember the term, but basically personal experience changes your view of a law. You're going to see a broader class of people benefiting from the ACA. Now, they may not be so excited when they get their tax bill in 5 years and have to pay for it, but in the meantime, they're excited. Plus, COBRA benefits have been expanded under the American Rescue Plan. Now, the test is going to be these provisions are only in effect, I believe, for about 2 years. And so if, as I certainly hope, the pandemic has faded in 2 years, the question's going to be whether there's the political constituency to keep those benefits in place. My guess is that there will be, because people will have experienced it. There were also good economic reasons to get rid of the cliff that existed under the old ACA, which I had done a fair amount of research about. That is, if in the old days, if you weren't 399% of federal poverty level, you could get a pretty generous subsidy for a lot of policies. But you get a raise and your income goes up to 401% of FPL, suddenly that goes away. That is a very peculiar system that I think it's very difficult for anyone to endorse. That has now gone away, at least for the next 2 years.
Thank you for that. Our next question, I think, addresses some of the finer print of the Affordable Care Act, which exceeded 1,000 pages, as I recall from when I gave it a very thorough read back in the day. And one of those questions is about electronic record keeping, which was, as I recall, one of the requirements for doctors to transition, healthcare providers to transition to electronic medical record keeping. So the question is, to what extent did EMRs or electronic medical records, how have they affected health and healthcare? And I think probably this best to start off with Dr. Woodard, but I'd also be curious from Professor Clark if this at all registered in public opinion polling as something that people valued in the Affordable Care Act. I suspect not. And then for Professor Chandler, whether there's been any sort of privacy implications, maybe under HIPAA or something like that, about electronic medical record keeping that has been raised by the Affordable Care Act. So we'll start with you, Dr. Woodard, electronic medical records.
So I think in general, people feel like electronic medical records are a good thing, right? They allow us to have, I think, easier access to our medical records. They allow us to communicate more efficiently, at least within healthcare systems. I think the challenge of electronic medical records, though, are a lot of the barriers that healthcare providers face. So healthcare providers, electronic medical records have imposed a lot more administrative work on healthcare providers, which make it sometimes difficult to deal with all of those administrative burdens while still, providing care. So I think that that's an important thing. We hear a lot about alert fatigue. So with electronic medical records, you're kind of continually being bombarded with information, and being able to separate out, the signal from the noise is a really important aspect of electronic medical records. I think the biggest thing where electronic medical records have failed to sort of achieve their promise is that our electronic medical record systems do not communicate. So we do not have a standard electronic medical record such that when you come and see me in clinic, if you went to another clinic, I would have access, to your medical records in that setting. So that lack of communication of medical records, I think, is one of the areas where electronic medical records have not improved quality in the way that we would like to see it. Also, I think that there's a lot that we can learn about healthcare and how we provide healthcare and healthcare delivery from having access to electronic medical record information. But unfortunately, again, we don't have good health information exchange. And so that limits what we're able to do despite capturing information in an electronic health record. So I think there's a lot of promise with electronic health records, but I think that there is still a lot to be accomplished. And until we find a way to have a more integrated electronic medical record, I don't think that we'll see the promise that exists for improving healthcare more broadly. And also the ability for information from social services, right, to be integrated with the electronic health record, because oftentimes, you know, most of what impacts the care of our patients is care that occurs outside of the clinical setting, right? So individuals who are having to access resources at the food bank or housing information, a lot of that impacts then health outcomes. And oftentimes we're just not able to access that information. So when we talk about an integrated healthcare medical record, we're talking not only about the clinical care that's happening, but also the social care and resources that impact health and health outcomes.
Thank you. Professor Chandler, Professor Clark, electronic medical records, ACA.
Yeah, I guess I don't have a huge amount of insight on the issue. What I would say, though, is there's actually another federal statute which seldom gets talked about, doesn't have any conferences devoted to it, which is MACRA. And what MACRA tends to do is to create these shadow pricing systems where the amount of reimbursement various providers get becomes competitive and depends at least in part on utilization of healthcare, electronic healthcare records. And so MACRA may have been a bigger force in really pushing electronic health records, even more so perhaps than the Affordable Care Act. On constitutional issues, you know, a little bit depends on what the Supreme Court says about privacy. There's a case before the Supreme Court this coming term, which deals formally with abortion, but abortion is intimately related under current constitutional doctrine to privacy. And so to the extent that the Supreme Court chooses to say, well, I don't see privacy anywhere listed in the Constitution, that could have an impact on whatever constitutional protections there might be against abuse of electronic health records. But in general, you know, if the government is paying for it, the government has a right to details, and distasteful as it might be, your privacy protections against government maintained records or government requirements that practitioners maintain secure records, not records that just get all over the internet, I think is somewhat limited.
Thank you. Professor Clark, electronic medical records, did they register on the needle in politics?
So I haven't seen any data on this particular issue. One thing in general, though, that we know from, you know, decades of public opinion polls and survey research is that in general, the public lacks political information and interest. Not everybody, you know, there's always that minority within the public who would be reading the 1,000 pages of the bill. But I suspect that, you know, something like the electronic medical records wouldn't necessarily sort of hit the radar of most members of the public. And so that's probably why we haven't seen a lot of polling data on that particular question. So it probably doesn't necessarily move the political needle per se.
Well, and that's another thing I'm glad you brought up, which is that when you ask the general public, as you showed in that longitudinal polling about the Affordable Care Act, yay or nay, you know, there's a fair amount of stability, you know, especially if you disaggregate by political party. But if you ask the public in public opinion polling about specific policies in the Affordable Care Act, even going all the way back to the early days after implementation, there was, generally speaking, overwhelming positive support for just about everything but the individual mandate. Even there was Republican support for most of the other provisions of the Affordable Care Act when you disaggregated them. So it's really the individual mandate where the kind of lightning rod of the Affordable Care Act in the early days and afterwards. And some of these smaller provisions people may not even associate with the Affordable Care Act.
Yeah, exactly. And actually, if you polled asking them about Obamacare versus the Affordable Care Act, you would get vastly different opinions. And you can guess which was sort of more partisan, right?
Yes, thank you.
Obamacare in general.
Exactly. Well, listen, we are at 7:30, so I think we had better wrap this up. I want to, before turning it over back to Dr. Panelists, thank our panelists for joining us tonight. I want to thank so much Dr. LeChauncy Woodard, Professor Seth Chandler, Professor Jennifer Clark. Thank you so much for joining us and talking about your perspectives on the Affordable Care Act, your discipline's perspective on the Affordable Care Act, and for entertaining the many wonderful questions from the audience. Thank you so much. Back to you, Monica.
Thanks so much, Jimmy. I want to thank all of our panelists as well, Dr. Woodard, Dr. Chandler, Dr. Clark, and Dr. Schafer for your very deft moderating skills. And of course, to all of our audience members for being with us this evening. Clearly, the story of the Affordable Care Act is one that is still being written on many fronts, and our presenters have given us a lot to think about this evening. Additionally, I'd like to give a special thanks to our program manager, Wes Jackson, and to Iggy Harrison, Lauren Gaw, and the entire team at Streaming Media for all of the hard work that they do to produce our online events. To learn more about who we are and what we do at the Center for Public History, please visit our website at uh.edu/class/CPH. Again, we appreciate your time. Thank you for being a part of this event. Good evening and take good care. Bye-bye.